Hello and welcome to Noble Mind.
Noble Mind is a podcast exploring mindfulness, meditation, and psychology.
Before we get started, I want to invite you to come to Unwind, a free drop-in practice session that I'm leading each week on Zoom. It lasts about 30 minutes and just long enough, hopefully, to fit between all your other tasks and to-dos. Each week, I give a brief science-backed tip to help with stress management or well-being enhancement. Then we spend about 15 minutes in a guided relaxation, meditation, or contemplation practice. Lastly, we end with a few minutes for discussion and personal connection. I encourage people to make the session work for themselves, so if you prefer to call in or keep your camera off, that is just fine. You can get more details and sign up to get the Zoom link and call-in information at drkateking.com/unwind. Hope to see you there. Hello, I'm Dr. Kate King.
And I'm Alex Gökçe. In this episode, we talk to Dr. Fabrizio Didonna about obsessions, compulsions, and his new mindfulness-based approach to treating the mental processes that underlie these symptoms.
Dr. Didonna is an internationally known clinical psychologist, a professor at the University of Barcelona, and a visiting professor at Shanghai Jiao Tong University. He is the developer of mindfulness-based cognitive therapy for obsessive-compulsive disorder. He's a founder and president of the Italian Institute for Mindfulness and a unit coordinator at Villa Margherita Private Hospital in Italy. He has been practicing and teaching meditation for many years and gives workshops and trainings worldwide.
You can get this episode's show notes and join our email list at noblemindpodcast.com. We hope you enjoy this show.
Welcome. We are here today with Fabrizio Didonna. Thank you so much for joining us on Noble Mind.
You're welcome. My pleasure.
Maybe we could start off with just having you tell our listeners a little bit about yourself and your work and your interests.
Well, I'm a clinical psychologist and also a father. These are my main jobs or missions in life. I'm also a director of a specialized unit for OCD and a unit for mood and anxiety disorders in a private hospital in Vicenza, Italy. Vicenza is a little town close to Verona and Venice. But I am also the director of the Mbct for OCD Center in Vicenza as well. I'm also a part-time professor at the University of Barcelona in Spain and a visiting professor at the Shanghai Jiao Tong University in China, where I collaborate in several research projects about the effectiveness of the Mbct for OCD program. My therapeutic background is in CBT, in cognitive behavioral therapy, and my interest in mindfulness started at the end of the 90s when I began to meditate myself, and gradually started to introduce meditation in my clinical work with patients affected by severe disorders admitted in an inpatient setting in the hospital where I work. Then I attended the workshops and trainings with John Kabat-Zinn in MBSR and with Zindel Siegel, Mark Williams, and John Teasdale in Mbct for Depression, and many others, and also others training with others leading mindfulness-based teachers and authors. And I started to share the possibility to adapt these mindfulness-based programs for obsessive-compulsive disorders with them. And what I found in my clinical experience is that mindfulness and self-compassion, when integrated with CBT, are probably the best approaches for this kind of problem, because they directly address the main cognitive biases and the mechanisms that activate and maintain OCD. So after about 10 years of trial and error, I was able to standardize the final protocol, which is now explained, illustrated in the Mbct for OCD manual, published last year by Guilford Press.
Fabulous. Thank you. And I'm wondering, for our listeners who may not be as familiar with mindfulness-based cognitive therapy or even obsessive-compulsive disorder, if you could, maybe we'll sort of step back and just kind of help people understand these ideas of obsessions and compulsions generally. You know, in the US at least, the words are really thrown around in very non-clinical ways. People might say, I am obsessive about having a clean home, and all they mean is they prefer things to be clean. So maybe you could just help explain what these words sort of mean, what they don't mean, and maybe we can go from there.
Yes, I think this is a really interesting question because first we have to consider that in psychopathology there is always a continuum between normality and pathology. It means that any of us can experience various attitudes, behaviors, or thoughts or mental states that may be considered pathological when they become too frequent, intense, and enduring. So, as is the case with most psychological disorders, OCD originates in normal and potentially adaptive human attitudes, habits, and also behaviors, which turn into a psychiatric disorder when they become too intense and or frequent, causing distress and compromise or interfering with the daily functioning. In fact, we know that most people experience intrusive thoughts and engage in rituals, and that these habits start developing in normally in infancy and childhood because they provide a sense of organization, balance, and safety and control in daily life. For example, we carry out a certain set of behaviors in the same sequence every time we do them. We may keep certain objects in the same place, or we eat the same foods in the same order. For example, for breakfast every day. In my case, for example, I eat the same biscuits for probably 40 years, and it's very difficult for me to change. We have intrusive thoughts whose content is not different from the intrusive thoughts that people with OCD have. This is also interesting. And our culture, social lives, and religious practices are characterized by rituals, by ritualistic behaviors that regulate, coordinate, and organize our relationship with the outside world and as well as our inner worlds. But even though rituals can give us a sense of order and stability, we have to continually adapt them to what is going on in our lives to remain functional. Mm-hmm. In people suffering from OCD, the triggering of certain psychopathological mechanisms leads to an often serious distortion in the duration, frequency, and intensity of behaviors that were initially normal. In turn, this distortion leads to the development of their complex and disabling disorder. Mm-hmm. So, with respect to the clinical obsessions, this is the main question. Clinical obsessions are often considered to be, or normally are, thoughts that express doubt or an hypothesis or an inference that the person experiences as being intrusive and negative and inappropriate. They normally cause anxiety, distress, or other negative feelings that lead the person to try to get rid or neutralize them by performing a compulsion or a ritual. They are normally connected to so-called inflated sense of responsibility, which is a strong, scary idea that the OCD sufferer could be responsible for a terrible consequence to themselves or others if they do not act, if they do not do something to prevent that consequence. Some examples of obsession can be, maybe I didn't lock the door this morning, or maybe I forgot to turn the lights off, or I might be dirty, I might have caused an accident with my car, or another typical obsession is I might kill a family member by using knives, poisons, or a car, or fear of being contaminated or contaminating others by infections or disgusting substances or objects. Mm-hmm. This is a typical clinical obsession. And on the other side, the clinical compulsive behaviors normally are repetitive behaviors or rituals associated with the disturbing emotions, in particular anxiety or disgust, that the individual feels compelled to perform over and over again. And the aim of these behaviors is to prevent or reduce the distress caused by one's obsessions, or to prevent, neutralize, or counteract obsessions themselves, or make them go away. In other words, the compulsions help reduce an individual's perception that he or she is or has been responsible for hypothetically harming him or herself or others, and make the person feel more comfortable, or that he or she has done the right thing. For example, people with contamination obsessions can decrease the mental distress they experience by washing their hands over and over again until their skin very often becomes cracked and dry. Or people with obsessive fears of intruders may check and recheck doors, locks repeatedly. Or others may check that the gas light or a tap is off. Or driving around to make sure that they haven't run over a pedestrian. Mm-hmm. People with obsessions about order can try over and over again to arrange things seeking symmetry or perfection. Or other may need to count in certain patterns, or have to silently repeat special words or phrases. Mm. Or people with blasphemous obsessions can engage in excessive praying, or in behaviors triggered by religious beliefs or fear. So these are the most typical obsessions and compulsions.
Mm-hmm. As you list those, I'm just really struck by how much suffering it must cause to have some of those thoughts you describe are just so troubling, to imagine that you might have hit a pedestrian and not know it, and then to have to drive in circles to check and recheck whether that's happened or not. It just sounds like a tremendous amount of pain. So, and just to clarify, the obsessions are the sort of thoughts that you're experiencing that have become really intrusive and emotionally sort of distressing and problematic. And then the compulsions are those behaviors that you're sort of compelled to do to try to manage the distress that those thoughts are causing.
Yeah. Another criterion is that both obsessions and compulsions cause distress and suffering in terms of disturbing feelings and emotions. But you also have to consider this continuum between normality and pathology in OCD.
For example, I remember hearing that fighter pilots are known for having a lot of rituals and superstitions, for instance.
Yeah.
So even people that society sees as super brave, when faced with
This is very, very normal because, in particular in Italy, in south of Italy, the magical thinking and superstitious thinking is quite normal.
Uh-huh.
So it's very interesting to see what is the limit, the border between normality and pathology.
What may be potential root causes that lead people to be more vulnerable to developing OCD?
As with the most psychiatric disorders, research has not yet been able to identify definitive and clear causes of OCD that are common to all individuals with this disease. Particularly because, OCD is a really heterogeneous disorder. It is very difficult to find all the possible causes of these different types of OCD. But there are a range of factors and conditions that have been identified as contributing to the development and maintenance of OCD. And it is likely that several factors are involved for each individual affected by the disorder. We know, for example, that there is a specific interaction between genetic and biological or neurobiological predispositions, also environmental factors, for example, life experiences, parental modeling, education, or a hereditary component. So there is quite often a father or mother with OCD or an obsessive personality. And also we have to consider attachment history. So the particular relationship that the infant or child developed with his or her primary caregiver, normally the parents. And all of this can drive an individual towards the development of OCD.
Are there similarities and differences between a more characterological presentation of OCD versus OCD as an Axis 1 clinical disorder?
Yeah. Characterological OCD is normally called in psychiatric terms Obsessive-Compulsive Personality Disorder, or OCPD. It is characterized normally by extreme perfectionism, order, neatness, and rigid adherence to rules. We can say that they have an obsessive lifestyle and the way of being. So they do not have normally obsessions and compulsions like in OCD. But people with OCPD often feel a severe need for control and to impose their own standards on their outside environment. And for this reason, they often feel indignant and angry with other people because, of course, most people are not available to follow their rules and they also find it hard to express their feelings, may have difficulty forming and maintaining close relationships with others, and they are often hardworking, but their obsession with the perfection can make them inefficient. People with OCPD have no idea that there is anything wrong with the way they think or behave. They believe that their way of thinking or in doing things is the only correct way, and that everyone else is wrong. So critical elements in the differentiating OCPD versus OCD are the obsessions and compulsions normally. A person with OCPD will have some rigid behaviors, but they will not engage in the overwhelming need for repetition linked to OCD compulsions. Another basis for determining OCD versus OCPD is the level of insight and self-awareness. Most often, person is fully aware of OCD and the problems it causes. But OCPD is different. A person with OCPD usually believes their thoughts and behaviors are normal, and other people are the ones who need to change. If you want to see a clear example of an OCD plus an OCPD, you can watch the wonderful film with Jack Nicholson.
Oh, right. As Good as It Gets.
Yeah.
Oh.
Yeah.
I've also heard you say that OCD attitudes and behaviors are common in several disorders that are not all OCD, such as eating disorders.
Yeah, that's probably the reason, because in the last DSM, the DSM-5, OCD is now the main disorder of a spectrum, because it is quite clear that many psychological problems have components, very similar components, several components very similar to OCD, and in particular, repetitive behaviors or rigid schemas or intrusive thoughts, worrying, and so on. So we can find obsessive behaviors in eating disorders. We can see intrusive thoughts in generalized anxiety disorder or hypochondria, health anxiety. It is quite strange that hypochondria or health anxiety is not included in the OCD spectrum in the DSM-5, because in my experience I found that hypochondria is absolutely, definitely an OCD problem. What is different is just the final contents of their obsession, but I also have several patients in my Mbct for OCD group with hypochondria, and I found that it is very helpful for them because they have, I think they have the common mechanisms and biases that leads to that form of OCD.
Do you see any relationship between compulsive behavior and addictive behavior? I know some people talk about compulsive shopping or compulsive gambling. So sometimes it seems like those words are used loosely, or people talk about behavioral addictions or process addictions like sex or shopping. Do you see connections there, or do you see that as part, or how would you differentiate that, or would you?
I think this is also an interesting question because I don't think these terms are actually appropriate. So the term compulsion linked to sexual behaviors or shopping and so on. When we talk about problematic shopping, sex or gambling, we are referring more to impulsive, not compulsive behavior.
Mm-hmm.
Just because these actions and attitudes might be experienced as uncontrollable, they are also pleasant or exciting and not performed continuously in a repetitive way. Differing greatly from obsessive rituals, which normally create distress and negative feelings. In fact, I normally use uncontrolled as a way to describe shopping, sex, or gambling, and not compulsive.
So compulsions are experienced by the person as unpleasant, even though they feel compelled to perform them. Is that right?
Yeah, compulsion normally are experienced with suffering, with anxiety, or with disgust, with a lot of distress.
So let's talk a little bit about mindfulness-based cognitive therapy for OCD. This is an innovative treatment that you've developed, and we'd just love to hear a little bit more about, how you think of mindfulness and how, the ways in which it is helpful for OCD, and a little bit about the treatment.
Yeah, Mbct for OCD developed from the need to integrate what is currently most effective in treating this challenging condition with the principles and practices of Buddhist psychology, focusing not so much on the symptoms of the problem, but on the processes that activate and maintain this clinical problem, which result in particular from the relationship people have with their private experience. And what I noted throughout my long clinical experience of using mindfulness for OCD with, I can say, hundreds of patients, was that patients responded well to these kinds of meditation practices and approaches, and very often found consistent relief from their problems by changing their perspective and the relationship they had with their internal experience. And by internal experience, I mean thoughts, emotions, and sensations. And this change in perspective is one of the main therapeutic factors in these approaches. There is a wonderful quote from the Anguttara Nikaya, which is an ancient Buddhist text, that explains, in my opinion, very clearly the sense of this change in perspective we want to develop through mindfulness to overcome OCD. And it says, not through actions, not through words, do we become free from mental contaminations by seeing and acknowledging them over and over. I think that's really interesting because this quote summarizes core meanings and principles of a mindfulness-based approach to OCD in several ways. It's a sort of Buddhist therapy of OCD, for OCD, because it highlights the importance of changing the relationship people have with their own internal experience, not the contents of the problem, obsessions and compulsions. And that's why I found that Mbct for OCD can be helpful also for other psychological conditions. For example, eating disorders or other form of anxiety disorders, or of course for hypochondria or health anxiety, because it intervenes in some common cognitive factors that are common in several psychological disorders, not to the specific final result of those mechanisms. So this is one important key feature of Mbct for OCD. But there are also some other core features of this therapeutic model. One is understanding, which means helping participants to gradually develop a deeper and clearer understanding of how OCD works. For example, causal, activation, and maintenance factors and mechanisms, and how mindfulness training can effectively intervene in replacing those factors and mechanisms with the new healthy and adaptive behaviors. In fact, I often say to participants in my group this sentence, understanding is the first step to healing.
Mm-hmm.
In fact, the first 2 or 3 sessions of the program are dedicated in particular to this factor, to this aim, so understanding. Another important key factor in this model is normalizing. So participants come to see that their reactions are not as unusual, strange, or crazy as they had previously thought. When the behaviors, ideas, and the convictions that are considered normal for most people become extremely frequent and intense, one of the possible results is the development of OCD. So mindfulness practice can serve as a powerful tool in the process of normalization, because it allows participants to see reality for what it is and to understand how the mind distorts it in several ways. And a further core feature is in this model is trust. So it is a really important to help participants to develop a real and mature feeling of self-trust, since mistrust can be considered a basic component in OCD, and the one that activates and maintains most obsessive symptoms. I also define OCD as a trust disorder in my manual. Of course, another important key feature of this model is an intensive training in mindfulness and self-compassion. Since they can help participants develop new mental habits, attitudes, and states, such as awareness, decentering, acceptance, wisdom, and compassion, that can effectively change or neutralize their obsessive mechanisms and biases. There are also other important factors, but
that's a fact. There's so much to go on right there. One thing, as you were talking, is really your underlining of obsessive-compulsive disorder as a trust disorder. I'd love to have you unpack that part a little bit more, because it's not entirely apparent.
Yeah, this is one of the main aim in my work and also in the manual. You will see, because it's not specific only for OCD, but in OCD it's very clear that mistrust is the main factor that leads these people to obsess themselves and to perform, to act in a compulsive way, because actually they do not trust their memory, for example. They do not trust their perceptions. They do not trust their intentions. And everybody, if you also do not trust your intentions, memory, and perceptions, probably at a certain moment you will start to have several obsession, intrusive thoughts, and try to defend from them through compulsions and rituals.
Yeah, I can see that clearly if I imagine myself not being able to trust those sort of foundational aspects of my experience or my thinking, that I'd probably pretty quickly develop some set of rituals or behaviors to try to manage that.
Yeah.
I'm struck by your approach from having read your book, that like Paul Gilbert talks about how compassion is the courage to descend into human suffering. And it seems to me the standard approaches to treating OCD are more focusing on symptoms, whereas your approach enters into the experience of the person. Like, what is it that they're struggling with exactly?
About the senses.
Right, about the senses, about why things are happening, instead of just changing the frequency of a behavior without looking at the root and branch.
Yeah, as I told you before, in the MBCT, the aim is not to change the intensity or the frequency of the problematic symptoms, so obsession and compulsions, but the aim is to help these people to change their relationship with the internal and external experience. That's why MBCT can be transversal to several problems, psychopathological problems. And mindfulness and compassion are trainings that can be really powerful in order to change our bad habits, our pathological habits, in particular mental habits that drive to this kind of problems. And that's why I introduce in this model also compassion as an important component. And this is quite different from MBCT for depression, in which compassion is an indirect component, but not specifically included in the practices of the program.
So it's about transforming the way the person is relating to reality, to their emotions, thoughts.
Absolutely.
Yeah.
OCD people have a big problem in take care of their suffering, and actually they create their suffering over and over again, and they are not able to understand that the biggest suffering that they create is not the one they fear to experience in the future, but the one that they create moment by moment with their problem. This is also another important reflection that we have during the group, and explanation of why we use self-compassion at a certain moment in the program.
It seems to include sort of radical validation of the person's experience, trying to get them to connect to what's their inherent wisdom or develop their inherent wisdom, but also acceptance of both reality and emotional experiences, and the self-acceptance, as well as self-forgiveness. So it's really sort of multidimensional.
Yes, I also introduce a practice which is called self-forgiveness, which has many connections, of course, with self-compassion, where self-forgiveness is sort of self-acceptance practice, because people affected by OCD need to develop an acceptance about their condition of fallible and imperfect human beings.
Mm.
And this is very difficult for them to accept.
This sounds difficult for everybody on some level, but this.
Yeah.
Right.
Yeah.
So it almost sounds like Plato's symposium, sort of like or academy, in the sense that the issues being addressed are fundamental philosophical issues, almost about life and how to have meaning, how to relate to their various things, as opposed to stop doing that. And just to underline for listeners, MBCT for OCD combines mindfulness-based stress reduction, mindfulness-based cognitive therapy, compassion-focused therapy, and acceptance and commitment therapy components.
Yeah, I try to integrate in a rational way all of these mindfulness-based approaches. Of course, the main approach is MBCT, but MBCT derived from MBSR. We have about 80% of MBSR in MBCT, but also compassion-focused therapy is an important approach that I included in several parts of this program, in particular in the cognitive evolutionary explanation of OCD. That is an important part in the first chapters of the manual. And cognitive evolutionary explanation of OCD gives an important rationale of this model, MBCT for OCD model.
Mm-hmm.
And there is also part of ACT, or acceptance and commitment therapy, in particular in the use that we do of metaphors in several practices, meditation practice. In ACT, metaphors is an important component, because I found metaphors are very effective to help people to develop metacognitive skills, and to develop some mindfulness skills such as decentering, disidentification, and also OCD. People with OCD found very helpful some metaphors that we use in the program in order to develop the skills.
I'd love to talk a little bit about exposure as it sort of shows up in MBCT and your thoughts on that, because generally the quote gold standard treatment that people get recommended to when they get diagnosed with OCD is exposure and response prevention, which is a pretty intense protocol of, having to expose oneself to the things that one most fears and enduring the fear and anxiety that arises and learning that the feared outcome doesn't happen. And I know there's some exposure in your protocol, but I'd just love to hear your thoughts about what mindful exposure brings to the table and how it maybe changes a little bit from the sort of traditional treatment that's on offer out there.
Yeah, well, MBCT for OCD is designed as a comprehensive and integrative approach to OCD, not as an alternative to CBT, because it actually includes the most important components of CBT. In fact, I introduced in the program an important practice, an important exercise, which is the mindful exposure, which is an integration between mindfulness and ERP that can better help people with OCD to accept exposure, which, as you know, is a very anxiety-evoking procedure technique, and this is the cause of a lot of dropout from the therapy. In mindful exposure, the approach is really different, because person enter into the situation, the obsessive situations, in a mindful state. So they practice a mindfulness exercise before to expose themselves, and then when they are in the situation, they use all the mindfulness skills they learn in the program, because we introduce mindful exposure in the 8th session of the program, so they learn a lot of skills. So when they expose to the obsessive situation, they enter in the situation with an attitude of acceptance. They are able to decenter themselves from the thoughts that come up in that moment, intrusive thoughts that come up. They are able to give value and validate what their senses say to them in that situation, because we say that the senses are the best antidote to the doubts, to accept the doubts. So they experience a really different approach, a different experience compared with the classical behavioral ERP. And normally what they noticed is that anxiety do not increase so much during this kind of exposure. They're able to stay in touch with the situation without the ritualize. And normally they are able to neutralize this kind of problem, this kind of situations in a few sessions, in a few practices, in a few sessions of mindful exposure. This is very interesting. But another thing, important thing is to know is that research data show us that standard CBT is a very effective therapeutic approach. Is a gold standard. But it also has been shown to have some limits. In fact, we know that about 50% of people suffering from OCD treated with standard CBT do not respond well to the treatment or relapse, as we told before, or relapse after a certain period. We have now some preliminary data. In particular, we have an open trial and 2 randomized controlled trials that show Mbct for OCD is very effective at the end of the treatment, and that the outcome is maintained at follow-up. We need, of course, further research to demonstrate if Mbct is more effective than CBT, but the preliminary data are really promising. Furthermore, we have to consider that Mbct for OCD, when it is provided in group, can be more cost-effective than individual standard CBT. It can also be more helpful for people with a comorbidity. So when there is a simultaneous presence or 2 or more disorders in the patient, because Mbct for OCD, as I told you before, is not focused on the specific symptoms, on the general attitude and the relationship a patient has with his or her internal and external experience. So I think these are some of the most important issues to consider in using Mbct for OCD.
To give our listeners a sense of what's involved in mindful exposure, there's meditative sections at the beginning and at the end. There's a clarification of motivation, keeping the therapeutic goal in mind, and then having the client do their best to stay in contact with the disturbing situation. And also a great deal of openness about, like, what are the thoughts, sensations, emotions that are arising? Trust what you're feeling. Trust your senses. Remember, thoughts are not facts. There's acceptance thrown in there, using quotations almost like mantras to keep the person on track. So it's quite different, I think, from a classical ERP, unless I radically misunderstand ERP.
Yeah, it's very different, because the aim is not to wait that the anxiety increase at the maximum level. The main aim is to relate to the situation in a more realistic way as possible. So to see and perceive the things as they are, not as their thoughts say to them.
Yes, yeah.
Where can people find you, engage with you and your work? And how can people receive Mbct for OCD? How can clinicians get trained to offer it?
I think that the best way to get more information about Mbct for OCD, about my work and contact info, is to visit our official website. That is www.mbctforocd.com. It has important information regarding the model, regarding the program, workshops and trainings for professionals, centers that provide this therapeutic program, and also more info about the manual and myself. Actually, Mbct for OCD is in its infancy. Manual has been published just 1 year ago. But we already have some centers, for example, in China, in Israel, in Spain, in Italy. And I also hope we can have a center in the United States. This depends mostly on the training that we can give in the next future.
Wonderful. Thank you so much, Professor Didonna, for your time and for sharing your knowledge and thoughts with us.
My pleasure.
Thank you so much. Take care.
Thanks to you.
Thanks for listening today.
If you enjoyed this episode, we hope you'll hit subscribe, leave us a great rating or review, and spread the word. You can also go to noblemindpodcast.com to join our email list. You'll get a weekly behind-the-scenes message, news, announcements, and other special goodies we come up with just for you. Thanks for listening, and bye for now.